and I'm joined today by Dr. Narkhede to discuss marginal zone lymphoma. Welcome, and please give us a little information about yourself.
Hello, everyone. Thank you for having me. My name is Mayur Narkhede. I'm an assistant professor at the University of Alabama in Birmingham. My clinical and research focus is on lymphoid malignancies, with a special interest in indolent lymphomas and chronic lymphocytic leukemias. It's my pleasure to be here today talking to you about marginal zone lymphoma.
Well, welcome and thank you. We appreciate your time and expertise. We're going to jump right into our questions for today. Our first question, what is marginal zone lymphoma and how common is it?
Right. So, marginal zone lymphoma is a cancer of the immune system, mainly the B lymphocytes, which are part of your white blood cells. It's a type of non-Hodgkin's lymphoma, so it comes under that category. And there are three main types of marginal zone lymphoma: extranodal marginal zone lymphoma, nodal marginal zone lymphoma, and splenic marginal zone lymphoma. These three subtypes basically depend upon where it's diagnosed and where else the cancer is. If it's mainly diagnosed in the lymph nodes, it's called nodal marginal zone lymphoma. If there is associated enlarged spleen, then it's splenic marginal zone lymphoma, and all of the other cases are referred to as extranodal marginal zone lymphoma. In terms of how common it is, about 8,000 cases of marginal zone are diagnosed in the United States every year. We usually consider this as an uncommon type of non-Hodgkin's lymphoma. It's an indolent or slow-growing lymphoma and often incurable, with multiple courses of remissions and recurrences occurring over one's lifetime.
Okay, thank you. So what type of symptoms do patients with marginal zone lymphoma have?
The symptoms of marginal zone lymphoma mainly depend upon where we initially diagnose it. So for the common types of extranodal lymphoma sites mainly include the eye, stomach, or gastric region, or the skin. So if it's detected in the eye, it usually presents with symptoms of protruding of your eyes, one side greater than the other, blurry vision, or inability to close one's eye. If it's in the gastric or the stomach region, usually presents with symptoms of heartburn, acid reflux, gastritis, stomach pain, or nausea. Or if it's on the surface of your skin, it can present as skin rash or nodules, which are getting bigger in size over a period of time. These are extranodal marginal zone lymphoma presentations. The other category is basically nodal marginal zone lymphoma. The symptoms of this are more vague and diffuse. One might experience symptoms of night sweats, which are drenching, weight loss more than 10% of the body weight over the last 6 months, or fevers. We call these B symptoms. In addition to this, one might notice lumps in the neck, armpit, or groin. These are lymph nodes that are enlarged. And then lastly, the splenic marginal zone lymphomas present as pain or early satiety or needing to have frequent meals. Or sometimes people do notice hard lumps on the left side of their belly. However, majority of these lymphomas, marginal zone lymphomas, are accidentally diagnosed. A routine evaluation might lead to a diagnosis of marginal zone lymphoma for a totally unrelated reason.
Got it. Okay. So if a patient has these symptoms or their doctor notices, a symptom upon exam for something else, how do they then go about diagnosing marginal zone lymphoma?
Right. So if and when your doctor is suspicious or concerned about a lymphoma per se, the first step is to get a biopsy or tissue sample to see what really is causing the enlargement of a lymph node or causing some abnormalities. Now, these tissue slides or lymph node biopsies or other biopsies have to be looked under a microscope by an experienced pathologist. The pathologist uses special stains to see if there are mainly two things in the biopsy. First, if there are lymphocytes present, which is what the cancer mainly is, and if the lymphocytes are clonal, meaning they are the same type or cancerous. If these criteria are met, then a diagnosis of lymphoma can be made, but to diagnose it marginal zone lymphoma, additional specialized stains are to be done by the pathologist.
Got it. Okay. And then, if someone is diagnosed with marginal zone lymphoma, what is the standard of care for those patients?
The standard of care is kind of very variable depending upon the location and the stage of the lymphoma. One of the biggest factors we need to consider is, I mentioned initially, it's indolent, it's incurable, meaning this can stay dormant for many years before it causes any trouble. So we don't start treatment or consider treatment unless it's causing any distress or trouble to the patient. If it is causing local symptoms like pressure, pain, discomfort, or maybe systemic symptoms like the drenching night sweats, the fevers, the weight loss that I described, then that could be an indication of treatment. Another indication of treatment could be if the lymphoma is causing involvement of the bone marrow, and that's causing low white blood cells, hemoglobin, or platelets. That's another reason to consider treatment. Now, to talk about the standard of care, it depends upon where, again, the stage of the disease. For extranodal disease, for example, if it's only in the stomach, we call this gastric marginal zone lymphoma, and there are no other sites. If it is associated with a bacteria called Helicobacter pylori, then the treatment basically is antibiotics for 12 weeks, and that should be sufficient for getting the lymphoma under remission. However, if there is no bacteria associated and it's still only in one isolated spot, such as the eye or the stomach, radiation is an option to those sites. Surgery, such as taking removal of the stomach, which can be pretty intensive at times, but that's another option. And lastly, if it's spread throughout your body, then systemic treatment, such as chemoimmunotherapy, is a preferable choice.
Okay. Are there types of targeted therapies for marginal zone lymphoma, and what are they?
Sure. So the progress in marginal zone lymphoma has been very slow. The last biggest change to the chemoimmunotherapy combination was the introduction of rituximab, and that's probably in the year 2000. So rituximab was added to chemotherapy, and that was the biggest change to the therapy. However, in the last 1 decade, we've understood the mechanism or the pathophysiology of this cancer. We've understood that most of the lymphomas have a receptor on their surface called B-cell receptors, and these B-cell receptors drive B-cell receptor signaling, which leads to cancer. So most of the targeted therapies are targeted to this B-cell receptor signaling. One of the very first drug that was approved by the FDA was called Imbruvica or ibrutinib, and we still use that today. It's a very promising drug. There are other groups of drug called PI3 kinase inhibitors that's being developed, and there are a few drugs that are available to use in the market, but there are very few adopters of that. And then the third type of targeted therapy is an immunomodulator drug called lenalidomide or Revlimid, which basically alters the immune system to arrest the growth of the lymphomas. However, these targeted therapies are indefinite or lifelong, which means they are to be taken as long as the treatment works with acceptable side effects.
Got it. Okay. And are there clinical trials available for marginal zone lymphoma?
Yes. So with the realization and understanding that B-cell receptor signaling is crucial, for the pathogenesis or development of the lymphoma, there are many clinical trials being conducted for marginal zone lymphoma. As I said, it's an indolent lymphoma, and so you require multiple lines of treatments throughout your lifespan if you have this disease. So there comes a point where your doctor might think we've used a lot of options so far and none really works. Then clinical trials work better. Currently, there are the clinical trials are looking at next generation monoclonal antibodies, which are targeting a different receptor other than the rituximab, or a next generation B cell receptor inhibitor, which is similar to Imbruvica but with fewer side effects. And the other area of interest basically is developing these genetically modified immune cells called T cells or CAR NK cells to treat the lymphoma and to get a longer remission.
Okay, interesting. And so I know you mentioned that the most recent medication was from 2000. So we know with clinical trials that it takes a very long time, for medications to go through clinical trials and be available once that trial is complete. So, how important is it for patients to enroll into clinical trials? And, are there, is the participation low at this point, would you say, for marginal zone lymphoma?
Sure. So the last biggest advancement was Imbruvica, which is 2013. So it's been it's about time for a new drug to come out.
Yeah.
So the biggest challenge with the marginal zone lymphoma is it's a diagnosis of the older age group. What I mean by that is the median age of diagnosis is around 66 years. When you're diagnosed at, say, 66 and you go through multiple lines of chemotherapy, it might be about 5 or 10 or 20 years before you reach a point where your doctor decides, well, we need to think about something else. And by that time, you're probably in your late 70s or 80s.
Yeah.
You might have experienced a lot of damage, per se, to the bone marrow from chemotherapy or other toxicities from the cancer itself, lung damage or liver or kidney. These things make it difficult to be enrolled on clinical trials because most of the clinical trials have a strict enrollment criteria, as you need to be fit, you need to have good functional status. So therefore, it's been very difficult to accrue to clinical trials for marginal zone lymphoma. It being not a common disease also doesn't help. Right. However, we've tried to encourage patients as well as other providers to send their patients early on, because we can use an experimental drug with lesser side effects sooner versus an aggressive or more intense chemotherapy later on.
That's great. That's good to know. So, patients out there, should they be asking their doctors about clinical trials when they're first diagnosed?
Yes. So clinical trials, as I mentioned, I mean, when you get diagnosed initially with marginal zone, if your doctor makes a decision to start treatment, we need to keep thinking about what's next, because all of the therapies that's going to be started is not going to cure the cancer. It's going to get into remission. Mm-hmm. So if you get diagnosed with marginal zone lymphoma, there should be a discussion with your doctor if there's any clinical trials options available. These newer therapies or newer clinical trial options might add on to an existing treatment. So it doesn't mean you will be getting a placebo. It might mean you're getting a better treatment option with lesser side effects than what's currently available. So earlier engagement with your doctor is essential.
Great. Yep, that's good to know. Okay, it looks like we have a question from one of our viewers here. It says, can you please talk about diagnosis and treatment for extranodal zone lymphoma in the parotid gland? Is surgery recommended as for other parotid tumors? or radiation versus chemo, etc.?
Right. So the diagnosis of extranodal marginal zone lymphoma in the parotid gland is tricky because the parotid gland itself could be cancer. So making that distinction early on is essential. Many a times when I get these referrals, uh, the parotid gland's already taken out because the doctor is really concerned about a parotid gland cancer, which can be a little bit more aggressive. So if that's not the case and the parotid gland is still intact and it was a minor excision, um, my preference is to consider local therapy before considering systemic therapy if there are no other sites of involvement. So radiation is a perfect option for such conditions. However, one must remember when you radiate any organ that's lymphomatous or where the lymphoma is diagnosed, you can have long-term side effects from that radiation. In this situation, you will lose the function of your parotid gland, which makes your saliva. So dry mouth is common, dental caries are common, things like that.
Got it. Okay. So I think that's all we have for today. And I want to again thank you for your time, and we appreciate you sharing this information. It's very important to us and our viewers. And this event will be available on our website after today. So, I think we have one more question that just popped up. It says, I did not hear you mention bendamustine. I hear about a lot of people on the BNR regimen.
Yes. So when I mentioned chemoimmunotherapy, the chemo component is the bendamustine. That is the bendamustine, and rituximab is the most common regimen. The reason I didn't mention chemo because there are other options out there, which would be rituximab with a combination regimen called CVP, or there might be, your doctor might even consider more aggressive chemo like R-CHOP. So bendamustine rituximab is the chemoimmunotherapy of choice if you have a systemic disease at home.
Got it. Okay. And couple more here. I have one of them. I have extranodal marginal zone lymphoma, 4 years, 3 rounds of BNR last January 2020, ongoing debilitating nausea. No doctor knows why.
Very tricky. So seems like it's been 4 years from the question with persistent nausea. Without knowing much details about what investigations being done by a doctor, a common thing that comes into my mind is maybe evaluation of your stomach by an upper gastroenterologist, by an upper endoscopy to see if there is gastric involvement of your marginal zone lymphoma. That's a recurrence. Chemotherapy causing nausea for so long, I'm not saying it doesn't happen. It's relatively uncommon. I would be looking for other causes of your nausea.
Okay. Good to know. Thank you. And then what about marginal zone lymphoma in the lung? Even more rare question. That's the question. Is it more rare?
Yes. So marginal zone lymphoma in the lung, I think deserves a separate category. It's extremely challenging to manage. Most of the times they are notoriously small, but cause a lot of problems. The management depends upon what exactly is causing the issues. They are known to secrete a special kind of protein called IgM. There's a strong association. That paraprotein or protein causes a lot of trouble. So measuring the IgM is important. Radiation still, if it's just one spot or 2 spots, radiation would be better.